from our sales and service that we offer. And so, and looking to continue to expand that and minimize grants and foundation.
So, as you explained, communities pay to buy the chlorine.
Yes,
They do pay.
they do pay. So we can't sell our services. It's hard to sell training, you know? So we do that for free and we sell chlorine. And then over the course of the phases, after about 3 years, we can pull back our services because we don't need to keep training. They're higher
And then
level.
they keep on buying.
And they keep buying. And so one technician, so the difference is that one technician for 50 communities, we lose an expense. One circuit rater, 150, we can be break even pretty much.
One technician is supplying 150 communities.
Yes, with technical support.
And besides that,
Geographically,
One motorbike?
one motorbike, but so one circuit rater is 50 meters is every single month.
But they still want.
Well, just 50. So to support 150, it's visiting them maybe once a quarter as
Yeah.
4 times a year.
maybe at the moment.
And what is he checking when he goes there? He checks
Chlorine, just checking for chlorine residual as a surprise visit.
Okay.
And then now we're checking uptime. So we're talking with the community and discussing if there's downtime and if there's technical assistance needed, something broke or something.
Okay.
Um,
All right.
So it's mostly the chlorine, but also just building relationships. So then, you know, it's something trust. So we spend a lot of time. And then our phase 2, then we stop measuring chlorine with our technicians. We train the community to measure chlorine. They send us a technician with the results. So there's a lot of savings there. So we're not spending gas and time, but we can still monitor it. So we have very extensive database to monitor it.
But they pay for the test or you supply it?
So the chlorine is, we supply the reagent. That's cheap. It's one penny, you know, and it's very cheap. The bacteria tests, they pay for it. And they're doing it twice a year. So we have the lab, we'll collect the sample for them, we'll give them the result and they'll pay for that.
So that's no problem.
Yes.
Always a problem, but it's very low. I mean, it's like $20. You know, for the full test, $20. That's bacteria, physical, chemical.
Okay. And only.
Yeah. Because it's in-house,
No, we do in-house as well, but it's more expensive. Well, it depends what you test.
Yeah, of course. And so we're doing very basic chemical and biological. But so this is gonna help us. One, they're requiring 4 times a year and they're requiring 2 samples per community. So now we're gonna be 4 times the amount of testing.
I made the exact same calculation. Oh, I was sweating.
And we're like, how much capacity? Our lab is very small, and we're not at capacity. But now we're like 4 times. We don't have incubator space.
Nobody
The membrane.
Okay, thank you. It's so good to have you. When you presented it, I thought like, wow, there's the lab.
So but the reality is it's gonna be a lot more process oriented and then keeping track of which communities, because then we have chemical tests every 3 years or 5 years if they pass.
They require the 3 years in the
To start,
report.
and then if it's negative, then we can do every 5. But I'm mostly concerned how we keep track of our, 2,000 communities, who is submitting and who has met the criteria every quarter. So it's gonna be required a little bit more on us.
It is super challenging.
Because the community's not gonna want.
It will be super challenging.
And then the final thing is like, how do we keep it? It's a market-based approach. So are we giving it away for free?
Yes,
Or are we gonna charge just to keep skin in the game?
yeah.
So we don't mess up our own subsidized, we don't mess up our model.
And you say you are 50% now, 50 recovery rate?
Yes.
Interesting. Let's continue sharing experiences.
Okay.
I'm super open to that and
Yeah.
really happy.
And do you guys have grant funding?
We do have, we started like, we are the best, we're going to make it without grant funding. And as soon as we started dealing with small communities, isolated areas, hand pumps, it doesn't work. So you need subsidies. So we are trying to balance it and not subsidizing.
Yeah, of course.
Large systems, profitable.
Oh, okay.
Can they overtake some
Yeah,
other part of the
that's right.
maintenance? The idea is to create, when you go in one area, you mentioned it, the logistics is key in our environment. It's cost, it's organization, coordination, so on. So the idea is you go in one area, being able to provide water or assistance. It's not only the big nice village with the nice water network, but all the guys around as well. How do you do that? That's the challenge. And to be profitable.
Yeah, right.
So super challenging.
We've always been in rural areas, but we're seeing now in some of the urban, we've done some work in urban areas in El Salvador where the population is about 3 or 4 times the size.
Yeah.
There's money there. And we're like,
Exactly. So our work now is to try to balance that.
Yeah.
And if we have too many of the hand pumps and not enough of the weak ones, we won't make it.
exactly.
And the very thing we don't want to do is to drop some commitments we
Of
made.
course, right.
So we are struggling. So we have to go for it.
Yeah, and it's nice to have like uptime to help supplement part of it. And that helps us get
The
out.
problem is how much and how should they make the calculation, how much will they pay?
Of course, and that's what's completely up. in the
No, but
air.
this is the
The
right
question.
Next week we have a meeting with them to explain what is the cost for us.
Okay, good. I was gonna say, for this, okay, the same. So we're working through the costs.
Left to
And
realize.
this is what our costs are and what we need to recover. And so what do you charge for a bacteria test or for testing in general?
We don't charge. Actually, the most we have is that we run everything. And we, the return is just the payment of the user. So everything is included.
So but you own the water system.
We don't own, we run it for the government. We have a delegation, we have a,
It's supposed to be in the turret.
we have a delegation contract. Now, the challenge is the government says by law, you have to test once a year, which we do. But then going quarterly,
Yeah. But it's not like quarterly, it's quarterly times 2 tests, so it's 8 times.
Or maybe,
and you have, and on the system, at the source, in the tank, after the tank, so it's.
So we discussed that and we were saying that they're able to clarify that if for us, the source in the tank, we would do it after fluoridation.
Yes.
Because.
There's no use
Rather
to
than
do
always
it
be
before.
negative.
And for us, I mean, testing at the source and the tank, it's few meters.
Yeah, exactly.
It's just pumping from under some water up to the tank.
make chlorination in the tank, it's better than after the tank, you see the effect of the chlorination.
So the first home. So what is a typical water tariff? Average cost?
It's 0.7274 dollars cents
Yeah.
exchange rate per cubic meter.
Over cubic meter.
Yeah.
And then what's average consumption per household?
It's to give you on term of price, it's less than $2 per year per person. The cost for the user is having 7 liters per day.
For 1 point is about 1 to 2 cubic meter per day.
Oh, okay. So we're cubic meter per day
Per day.
For 500 people,
For
for the system.
no, for one standby.
one standby. If you have 4 standby,
You multiply by 4.
Okay. So our water tariffs are between 50 cents to $2 per household.
Okay.
But they're using
But
maybe one
per month, per day,
per month,
per month.
and but they're using maybe 1 to 2 cubic meters.
So it's not per volume. It's a lump sum.
no, we stay here, we want to stay here.
Security man.
No,
It's about
Application like, well, I. Question.
Yeah, great.
But I have to think, so I help you impress with the notes. That's great, thank you. I think it's like, well, for me, probably never, not wrong with it, so hopefully that'll be good. Yeah.
You want to check and see.
We're ambitious. I'm happy. I think, yeah, just remember, I do have. Just the lab manager, you make something, make magic happen. Whatever. Yeah. You can't do anything without a lab manager.
Yeah, so like, I guess 5 days. I guess. Yeah.
Oh, okay. From my. Yeah, I mean, that's more. I think I know why it's hard. Health and then you might.
Well,
Yeah.
you know, so, you know.
So you can go hard here, that's great.
We've been like playing. Like you had different matrixes.
Yeah.
There's. Yeah.
That's really cool. Innovation, yeah.
Yeah, Joe's. I think Joe's really.
So how many attachments do you have on a car now that you're doing?
Yeah, I mean, it varies, but it's usually like around that.
Yeah. I'll give you more than that.
Yeah, so like we do the 384 well, we did it 84, so it's like 48 targets total.
Okay.
And then like when you try it out, that's definitely like upper there.
You're trying to. Yeah, not big. So we're still looking at the kind of our America, we pay for machine time, we don't run it in our.
Right, yeah.
Yeah, when did Joe came during the pandemic
Yeah,
here, right?
basically.
Okay, so you had me and Boyd,
Yeah.
so were you there before and then? That's great.
Yeah.
And is the study in Mozambique is continuing or is it over now?
We'll see, I guess. But they are having a side event next tomorrow, Thursday. At the after.
That's great.
Like they were about like.
But right now it's not continuing that or? Yeah,
I'll let them.
I leave tomorrow, so I'm gonna have to
Oh,
look at
okay.
the recording, yeah, I'll be here for like part of the day that I have.
Yeah, sorry, it's not my project.
Okay, that's exciting. Yeah. What other countries? You're working in the South, right?
Yes, Joe currently, yeah, it was being the, yes. He's also doing.
Straight pipe, yeah, straight pipe, you're not saying straight pipe, yeah.
Yeah, because the soil down there is pretty impervious.
People are still doing that, but they're not.
Yeah, it's kind of like, because, yeah, even if they.
But as legal for that. Okay.
Yeah, I don't, yeah, like, cause there's the physical, like, I can't physically do much about it if it's the soil itself, and like anything that, or any technology knowledge, it's.
Yeah. I get a little bit.
Oh, yeah, no, honestly.
I think another 2 years. Yeah, I'll start a while, the one, so when I follow the 2 years.
Okay, I'm gonna get into point for the year. Or, otherwise, I already. Any questions?
No. Thank you.
Yeah.
Yeah, the stock right there on the street, like they did. And one and a half or house here and there.
Yeah, I imagine. Firehouse. I like no one's gonna buy it all. It's just so sad. Where it should have been. Really?
Yeah.
I'm included.
Yeah.
Where?
Yeah.
Oh, okay, yeah, I'm familiar. My sister went to.
Hi, Michelle.
That's the one that was in 2021.
I'm Yeah, yeah, in the medical school.
Yeah, I remember her talking about it there.
Yeah, but just Washington.
God.
Oh, really?
Especially in an urban area. Letting any hurt is bad, but.
Yeah.
Like where there's no. Full water paving. This is. Like there's not to it, but. All this black. What is that? Is that the? Yeah.
Yeah, but it's. Yeah, I didn't get any meeting here.
No.
Oh, okay. So now.
International.
Oh, wow.
Yeah, what about you?
I didn't say biology, that's engineering, so like academic, memory, very well. Bio. So, yes.
Yeah. Yeah.
It's my first year here.
Oh, really?
Yeah, when I every other year, so last year, we went. Now, part of my group went to ADHA and this year. The year ago. It was in Boston last year, and it's like a fun time, like the good experience. It's hard because first person I heard to do. I think there's some stuff I need to figure out where to go. It's like meet more people. But this was a great understanding. That's my first time hard. Oh, really? And you know, like COVID and everything, I didn't reason, but everything canceled. I was finishing up my project. So.
Yeah, I can't imagine what's happening.
It was rough. Living, going back to live with your parents at way I never thought it would happen. Like. Okay, I'm glad you're waiting. Sometimes people come in and like, well, the
Yeah.
slides going and.
Yeah. I've noticed, I feel like for that,
But
advanced people are a little bit.
trickling in.
Yeah. Yeah. I think the one, yes, or I did one. Or it's like probably like a quarter full at like 3 pass, but then like 10 minutes pass is like almost.
Yeah. It's great. So.
Yeah, okay, yeah. And it's nice because like after this, it's just a poster, so.
No rush.
All right, everyone, welcome to, this is Windflower, right? Yeah, I'm sorry, I got the names mixed up, but welcome to today's verbal presentations on water quality. First up, we have Christine Marie George from Johns Hopkins. So please welcome Christine.
Thank you. Good afternoon, everyone. So I'm Christine Marie George, and I'm a professor at Johns Hopkins. And it's my pleasure today to present on our randomized control trial of the community-led Strong Heart Water Study. And the objective of the study is to reduce arsenic exposure in partnership with the American Indian community. And this study is a collaboration between our research team at Johns Hopkins, Missouri Breaks, Columbia University, and Indian Health Service. And the rationale behind our work is that in the United States, there are estimated to be over 2 million individuals exposed to elevated arsenic from private wells that exceeds the maximum contaminant level of 10 micrograms per liter. And this map here is from the US Geological Survey, and it's showing the distribution of arsenic across the US. So the areas that are orange or red are where more than 25% of the water samples tested had arsenic above the MCL. And arsenic exposure disproportionately impacts rural communities, including American Indian nations. And so there was a study conducted to investigate the health implications of chronic arsenic exposure among American Indian communities as part of the larger Strong Heart study. And so the Strong Heart study is a longitudinal cohort study to investigate risk factors for cardiovascular disease in American Indian communities. And as part of this study, a urine sample was collected and tested for urinary arsenic as a biomarker of arsenic exposure. And so here on this map, I show the Strong Heart study communities, so all the tribal nations that were part of the study. And so through the study that was conducted, it was found that chronic arsenic exposure measured through urinary arsenic concentrations was associated with an increased risk for cardiovascular disease, cancer mortality, diabetes, kidney disease, premature mortality, and chronic lung disease. And so these findings showed that chronic arsenic exposure in these American Indian communities was associated with these adverse health outcomes. And this led to our current work, which we'll be presenting on today for the Strong Heart Water Study. And the objective was to develop and evaluate community-led interventions to reduce arsenic exposure in communities that were part of the Strong Heart Water Study. And again, our work focuses on private wells. And private wells are not regulated by the EPA. So the onus is on the private well user to ensure that their wells are arsenic safe. And so the Strong Heart Water Study program was developed through community-centered research, which was led by Dr. Elizabeth Thomas, who's in the room today. And community workshops were conducted where community members, including private well users, tribal people working within tribal government, for example, in the Water Resource Department, and the tribal water utility, community health workers, came together to discuss their priorities around drinking water and to develop interventions that were tailored to the needs of their community. And so here I show some photos from our community workshops and a ranking exercise that was done to prioritize communication channels to deliver this arsenic mitigation program. In addition, there were semi-structured interviews with these key stakeholders, which allowed us to identify the facilitators and barriers to accessing arsenic safe water within these communities. And so now I'll go through the different components of the Strong Heart Water Study program. So the first key behavior was identifying which wells were arsenic safe. And so community members went to households that had private wells and collected a water sample. And this water sample was tested at a local laboratory by inductively coupled plasma mass spectrometry for arsenic. And a total of 552 private wells were tested as part of this program. And 179 were found to have elevated arsenic, so about a third. And the results were shared with all of the community members. And so in addition, through the formative research that was conducted, community members requested information on the arsenic risks in their areas. And so this led to the development of these risk communication maps that I showed here. And so the results are anonymized in 5 mile by 5 mile grids. So an individual household cannot be identified. And so here's an example from one community. And so in red are areas where the mean arsenic concentration within the grid is above the MCL of 10 micrograms per liter. So this was a way for community members to be able to see the arsenic risk in private wells in their community. In addition, for households that had elevated arsenic, they were invited to participate in a Strong Heart Water Study component, which provided a point of use arsenic removal device. And so the device that was selected was Multicur, which is an absorptive media filtration device. We considered reverse osmosis. However, this really changes the taste of the water and it removes the minerals. And in the communities that we work with, the taste of the water was really important to them. And so this is why we selected this particular device through our formative research that was conducted. And so for the installation of this device, it goes under the kitchen sink. As you can see here, it's the cartridge is here and it goes into the metal canister. And then the water comes out here through a filter faucet. And this is promoted for drinking and cooking. And the main kitchen faucet remains for tasks such as washing dishes. Like, so we wanted to reduce the burden on the filter faucet so that people are only using it for drinking and cooking. And so for the implementation aspect, this was community-led, and it was community plumbers from the tribal housing authorities in these communities that were installing the arsenic removal device and providing a replacement cartridge. And this was done through a partnership between our partner, American Indian Nations, and Indian Health Service. So next, a key component was promoting the use of the arsenic filter for both drinking and cooking. Through our formative research, we identified that some households thought that boiling water removed arsenic, where it actually concentrates it. Other things that emerged, that people thought that it was okay to cook with water that had elevated arsenic because the cooking would remove this. And so it was really important that not just installing the arsenic removal device, but actually providing health communication information on the correct uses of the arsenic removal device. And so as one component of this, through our community-centered formative research, we developed a Strong Heart Water Study mobile health program, where a health promoter called households to provide counseling on the use of the arsenic removal device, and also sent text messages to remind them and also to follow up with them about any concerns they had. And this was rather timely as we conducted our randomized control trial through the COVID pandemic, where we could not make in-person visits. And also many of the households in our partner communities are very remote households that have private wells. And so some households may be, let's say, 20 miles off the main road. And particularly during the winter time, it's very difficult to be able to access households if there's a storm, for example. And so mobile health presents an easier approach to be able to get information out to households. And so in addition, we had a more intensive arm of our study where health promoters went to households and provided counseling on the use of the arsenic filtration device. We also had video testimonials from community members. And so the videos focused on the need to understand arsenic exposure in the community, to have your well tested. It focused on why it was important to use the arsenic removal device and overcoming challenges households may face. For example, having young children use it, they may not want to use the filter faucet, or they may forget to use it. And so that was the type of content that was in these testimonial videos. And these videos were shared through Facebook with households, through in-person visits, and also through text messages, a link to the YouTube video online. So in addition, as we all know in the room, a key aspect of installing a point of use filter is changing the cartridge over time. And so for this one, through our pilot that was done before we did our randomized control trial, we determined that it was 12 months was the recommendation for when to change the device. A video was made of a community member changing an arsenic removal device in a home to show households how to correctly perform this behavior. And these videos, again, were shared through text message and also through Facebook to households through the pandemic. And so we conducted a randomized control trial of the Strong Heart Water Study program in our partner American Indian community in the Northern Great Plains. And we randomized households to be in one of two arms. The first arm received a Strong Heart Water Study mobile health program and the point of use arsenic removal device. And then the other arm received the same intervention plus home visits, and this was considered to be our intensive arm. We followed these households for a mean duration of 2 years. And we collected urine samples from household members to test for urinary arsenic as a biomarker of arsenic exposure. We collected water samples from the filter faucet to assess its removal capacity over the 2-year study period. And we also obtained information from participants on reported use of arsenic safe water for drinking and cooking. So now I'll go into our results. So we found when we combined both study arms, so our mHealth arm and our intensive arm together, we observed a 47% reduction in urinary arsenic from baseline to our 2-year follow-up. And this result was statistically significant. We also looked at findings by study arm. And so when we looked at the mHealth and filter arm, we observed a 55% reduction in urinary arsenic from baseline to our 2-year follow-up, and that's shown here. And then when we looked at our intensive arm, it was actually less of a reduction. It was a 30% reduction from baseline to our 2-year follow-up. And in our intensive arm, we had implementation challenges with the home visits, given the COVID pandemic and the remoteness of the households, as I mentioned. Next, we looked at the removal capacity of the water filters, and we found that 93% of the filter faucet samples that were collected at the 2-year follow-up had arsenic levels that were below the MCL of 10 micrograms per liter. And so we had 3 filters that failed, and these were either from households with a very large size, over 10 individuals, or in households that reported not changing their arsenic removal cartridge. And these results were similar between the 2 study arms. Next, we looked at respondent reported use of arsenic safe water for drinking and cooking. So we looked at exclusive use. So this included using the filter faucet, bottled water, and the municipal water supply. All those were considered to be arsenic safe. And so when we looked at both drinking and cooking water, there was a significant increase between baseline and our 2-year follow-up on exclusive use of arsenic safe water, going from 12% to 46% for drinking water, and then from 17% to 53% for water used for cooking. So in conclusion, we found that the Strong Heart Water Study was effective in significantly reducing arsenic exposure, as measured by our biomarker of arsenic exposure, urinary arsenic, and that this intervention was effective even when we just had the filter being installed by a community plumber and provided mobile health messaging for reinforcement. So there was no additional added benefit of the home visits for intervention delivery. Through the study, we were able to understand the importance of a community-led approach for both the design and implementation of an arsenic mitigation program. And we hope that this can serve as a model for other studies that are interested in conducting arsenic mitigation. And then finally, the value of mHealth. So our group is rather passionate about mHealth. We use mHealth for this study, also for our work in Bangladesh and Congo. And it's just a low-cost, scalable approach to be able to reach households and to serve as reminders for performing wash behaviors. So that concludes the presentation today. And I would like to acknowledge our research team, including our partners at Missouri Breaks, which is an American Indian owned and run research organization, and Tracy Thacker, who was our project coordinator, as well as Marsha O'Leary, who's the director. I'd like to also acknowledge colleagues at Columbia University, Ananavas ASEAN, as well as my colleagues at Johns Hopkins who are in the room, including Elizabeth Thomas, who led our formative research, Hala Schwab, who was our technical expert on our team, as well as Kelly Andreas, who led our data analysis, and Darcy Anderson, who conducted our formative research for our program evaluation at the end of the study. In addition, I would like to acknowledge my colleagues at Indian Health Service, including Captain David Harvey, who was instrumental in getting the study up and running, as well as colleagues that are environmental consultants in our partner nations and in MedStar. And that concludes the presentation, and I would be happy to address any questions. Thank you.
I had a question.
My question just centers around the economics of it. How much were the filters and the filter replacements?
That's a great question. So we purchased these filters back in 2017, and they were $245 for the actual arsenic removal device, and the replacement cartridges were $55.
Thank you.
And the installation and the cost of the filter was covered by Indian Health Service for this project in partnership with the tribal government. And so the tribal governments received funds to have community plumbers and install the device.
Okay, I don't think I need this, but my question was, I know you said you tested for arsenic. Did you test for any other known health contaminants like lead or even bacteria?
So we did. So we also tested for uranium. The area that we're working in is known to have elevated uranium. And unfortunately, the filters that we have do not remove uranium. And so we only included households that had uranium below the MCL, and the ones that had uranium above, we referred them to Indian Health Service. There's a question in the back.
Hi, thank you. I really enjoyed this talk. I'm just curious, and maybe I missed it, the filter you selected, is that certified, the standard 53?
It is.
For arsenic reduction?
It is certified for
Okay.
arsenic removal. Yeah, that's very important. It's certified.
Thank you.
You may want to.
And I'm happy to address questions after also. And we have several publications that have already come out from this work that we can share.
So congratulations for the presentation, and how the user knows that that the filter is saturated. I mean, it depends. The saturation depends on the concentration of the arsenic.
That's a great question.
So how do they know that it's okay? Now it's time to change because there's it depends on the concentration of the arsenic.
Yeah, so that's a great question. So when we first started out, we had an indicator light with a flow meter that was measuring the water that was passing through. And then when it turned red, households would know when to change their cartridge. But we found that when we actually implemented that, that the flow meter didn't work well. And so we had conducted a pilot study of households that we followed for a period of 9 months before we conducted the RCT. So we had a good sense of the failure rate of the filters based on the household size from that. And so we made a recommendation of 12 months. But what's interesting is it looks like the filters last a lot longer than 12 months. We were being quite conservative because we wanted to ensure that people were getting arsenic safe water. But we need additional studies to look at the exact duration. But it really varies based on the context, right? Because if there's high silica in the water, the filters may not last as long. So we provide a recommendation to households, but as you said, it really depends on the chemistry of the water.
Yeah.
And like I said, I'm happy to answer any other questions. Thank you, everyone.
Next up, please welcome Joshelyn Guimaray from the University of South Florida.
Hi, good afternoon, everyone. My name is Joshelyn Guimaray, and today I'll be presenting on modified biosand filtration using aluminum hydroxide filter media to enhance fluoride removal. Around the world, fluoride is found naturally in groundwater, as seen in the map. Normally, there's minerals such as micas, apatite, and fluoride, which are rich in fluoride, and they contaminate the soil and the water. According to the World Health Organization, if people drink contaminated water about 1.5 milligrams per liter and higher, they have severe health effects. So one of them will be dental fluorosis and skeletal fluorosis. This usually happens when there's chronic exposure. Dental fluorosis you have when there's yellow pitted teeth. Normally your tooth enamel is damaged beyond repair. And skeletal fluorosis is when you have brittle bones and there's pain in your muscle and joints. This happens when there's chronic exposure to 1.5 to 3 milligrams per liter for dental fluorosis, and skeletal when there's 4 to 8 milligrams per liter. There are common fluoride removals methods using for centralized treatment, which are electrochemical, coagulation, ion exchange, and reverse osmosis. They're very effective, however, they're complex, they're expensive, and they rely on a lot of chemical processes. So for developing countries, you have to use point of use treatment systems. We do this by using an absorption method. The absorption method is very simple and it's cost effective. There are different absorbents for this method, and one of them is aluminum hydroxide. Aluminum is a metal ion and it has a high positive charge. So it has a high affinity for the ion for fluoride. So as we can see here, the fluoride is attracted to the aluminum, thus decreasing the fluoride levels in the drinking water. Since the absorption method only removes fluoride, we have to use a different method, which would be biosand filters to remove different pathogens and bacteria. Biosand filters are usually composed of a lid and outlet tube, filtration sand, and your separating gravel and drainage gravel. Normally, as seen in the middle, people usually pour the water in, the treatment goes through the system, and you get your clean water out. You can see in the table that normally they can remove protozoa, viruses, bacteria, and turbidity at high levels. However, for fluoride, you cannot. So the question is now, how do we remove fluoride pathogens in general? It's by combining both of these systems together. Normally, biosand filters are composed of sand, and they're not good at removing fluoride at all. So we have to coat the media so it can help with the fluoride removal and change the media to a different type so the one that has fluoride removal can enhance the coating. So there are different types such as zeolite, bauxite, calcite, charcoal, biochar, and pumice. Biochar and pumice, there's been different studies that have shown for short term for lab studies that they're good at removing fluoride. Thus, these are the two that I picked for my project. Biochar in general is a product of pyrolysis of organic feedstocks, while pumice is a volcanic rock. They're both inexpensive and they have a high porosity and high surface area, which allows for more water to be treated, so there should be less fluoride in general.
To achieve long-term consumption of clean water for families in developing countries, my research consisted of comparing which biosand filter media could remove fluoride and other water quality parameters the best for long periods of time. My research also consisted of seeing which coated media still had fluoride removal capacity before having to dispose the media and replace it with new ones. To achieve long-term.
For my project, I performed a lab scale experiment. And initially I had to coat the media. So I coated biochar and pumice. Normally I first washed it, I sieved it, then dried it, mixed it with aluminum sulfate, dried it once again, and mixed it with ammonia hydroxide. And lastly, I rinsed it with DI water. Before the column studies started, I did an absorption study to see how well the media would do in removing fluoride. We can see that coated biochar and coated pumice are below the WHO limit, so they removed and have a large absorption capacity. However, sand and oyster shells do not. I used for my column design, I had 3 columns, one containing sand, one containing coated pumice, and the last one had coated biochar mixed with sand. The sand was there, so biochar normally floats up. The sand normally pushed down the biochar, so it wouldn't float up. The oyster shells were replaced since they were used as a post-treatment. Since coated pumice and coated biochar, with my experiment, was having a low pH, and oyster shells are known to increase the pH. This is how it looked in the lab. Your uncoated sand. The middle was the coated biochar with sand, and then coated pumice. As mentioned before, oyster shells was used for post-treatment, and just a little more background, they're low cost, they're slow release alkalinity source, so they increase the pH, and it doesn't disintegrate rapidly, so it doesn't affect the turbidity in the drinking water. The parameters I measured were filtration rate, charge volume, fluoride, turbidity, E. coli, UV254, pH, and aluminum. For my fluoride, for my first graph, I'm showing my fluoride breakthrough graph. So I'm showing my fluoride concentration versus the days. My experiment lasted for 418 days. And I have my purple line that represents the pool limit. I have my blue line that represents the charge volume. So I increased the charge volume from 250 to 350, 750, and to 1,500 milliliters. The red diamonds represent the untreated water, while the blue circles represent the coated biochar. The orange represents the squares, pumice for coated pumice, and the green triangles represent the uncoated sand. So to initiate, there's a breakthrough for uncoated sand after 49 days. A breakthrough means that there was fluoride concentrations higher than 1.5. There was a breakthrough for biochar for 313 days, and there was a 90% higher removal. And lastly, for coated biochar, it happened after 418 days, which had a removal about 98% and higher. For my filtration rate, the acceptable rate was about 0.15 meters per hour. As we can see, there's red lines, so those are just when I cleaned the Biosand filter. Normally, when there's an increase in charge volume, my filtration rate also went higher. As time went on, the filter started to clog, so I had to clean it. And as you can see, anytime it was clogged, I cleaned it and the filtration rate went up. For UV254 and turbidity removal, as you can see in the graph, coated biochar did better in removing UV254, while coated pumice did better in removing turbidity. This is the E. coli graph, so we can see that biochar performed the best in removing the bacteria, while pumice and sand then came afterwards. After the experiment lasted for the 418 days, I recoated the media to see if there was any absorption capacity left over. And for biochar, there still was, like it was in the initial. However, for pumice and sand, the absorption capacity was exhausted. So there was no more removal for it. So for my conclusion, coated pumice did the best in removing fluoride and turbidity, while the absorption capacity was exhausted. And for coated biochar, there was the best for removing UV254, E. coli, and we could recode it to have the high absorption capacity, like the initial. I would like to acknowledge my professors, Dr. Erickson, Dr. Gaber, Michael, and Dr. Alfredo, the fellowships that have helped me along the way: Strong Coast, Ignite, Sloan, NF Doctorate, Bridge to Doctorate, the Joan McCann Foundation, and EPA. Thank you.
Congratulations, this is really very important research. I'm very glad you're choosing this topic. My name is Lisa and I sell water filters in Kenya, and fluoride is a huge problem there. And I'm very keen to develop mechanisms to see how now the products can be developed that can actually be sold to communities or provided to communities. So what is your recommendation for the next step? So now you have these findings. So like what kind of device or what kind of intervention or what kind of how do you call it? Device or system would you now recommend for like worldwide deployments? Or like, you know, to ensure that we actually can now reach those communities that suffer from fluoride, but now can start using this, like how to make this now applicable in the field.
Yeah, that's a great question.
And if you could share your email address and.
Yeah, definitely.
Thank you.
I'll be here afterwards to answer more questions, but in general, I would say, since I did a lab scale study, it would also be better to see how it does in a pilot and field scale. But my recommendation would be using biochar, since that one did have an absorption capacity afterwards. So it did perform very well. And even though you can recode it and everything, it'll still keep performing well. So there's less time that you're gonna have to like clean and to do a new setup. and you'll have more time to generate it.
Thank you.
Hi, my name is Peter from the University of Copenhagen. Just a small suggestion for your follow-up study. Try and look at the bone charts one. We've been using that in instance here for a couple of years and can actually treat quite a lot of work with that. And you don't have to code. The coding process, was it difficult or?
No, it was actually pretty simple. So the coding process that I got was from previous students that have been doing this process. And it took less than 2 days to do. It's just the drying part, I guess, was the most difficult part, just waiting on it to dry. But there's no difficult issue with it.
Hi, great presentation, thank you. Curious about the carbon source for your biochar and also how you selected it. And when you say you unclogged the filter, did you kind of just like agitate it, or what did you do to make it flow again?
Yeah, I agitated pretty much, since my columns were 2 liter, I could pretty much just get a stick and just try to move it and scoop it up to clean it. And the biochar that I used was wood chip biochar. Normally, as you know, biochar, there can be different types of feedstocks and the large surface area, but looking at different studies, wood chip seemed to be one of the best ones for fluoride.
Maybe one more question.
Thank you for the information. My name is Sarah from Water Garden. I was just wondering, what is the minimum amount of time that the water has to be in contact with the biochar for you to effectively remove the fluoride?
That's a great question. For my column study, I pretty much used about, depending on the charge volume, but it didn't take long, less than 10 minutes for it to have good removal in general. Yeah.
Okay, thank you. I'm Kathleen Hohweiler. If you want to implement this on the household level, in terms of cost, how much would it be? We have a challenge in one of the districts we're working in Ghana, in their high inflation. So I'm interested in the costs because the number of communities to run. Thank you.
Cost-wise for Biosand filters and filtration, I don't have the exact number, but biochar itself is very low cost in general. That's why they're known to be used in developing countries overall. So I'm guessing it will be less than what you would expect than other products that you would have to like manufacture and so forth.
Cool.
Step, please welcome Kathleen Hohweiler.
Thank you.
Virginia Tech.
Thank you. Hi, everyone. Thank you so much for coming to my presentation this afternoon. Today, I'll be talking about a pilot study that we completed in collaboration with the USGS, where we looked at the occurrence of per and polyfluoroalkyl substances, or PFAS, in private drinking water systems in Southwest Virginia. So if you're not familiar with PFAS, PFAS is a larger name for a group of chemicals estimated to be in the thousands that are highly fluorinated, as well as considered to be virtually ubiquitous in consumer product. So this includes things like clothing, cosmetics, non-stick pans, you name it. And it's also been detected in a variety of environmental matrices, including soil, water, and air. And essentially, PFAS is considered to be virtually an everyone problem. This is not just a global, or this is not only a US problem or a urban problem, rather this is both a rural and a private system problem. So ultimately, our group is interested in private drinking water systems. So about 10 to 20% of Americans are reliant on private drinking water supplies. And when we're talking about private systems, we're interested in 3 main groups, which include wells, springs, and cisterns, which were the focus of this study, which mostly were wells and springs. So like was mentioned in a previous presentation, private wells are obviously not subjected to the U.S. Safe Drinking Water Act or SIDWA. However, we can use SIDWA as a bit of as a guideline for recommending health and determining the safety of a private system. From previous work done by our group, we've noticed that treatment prior to consumption is rather limited. So this includes things like GAC filters at the point of use or under the sink, like reverse osmosis. And so even participants who have had their water tested in the past, sometimes implementing treatment techniques is rather limited. And at this time, there's very few data sets describing PFAS in household drinking water systems under baseline conditions. It's really common to start testing for a contaminant of emerging concern after there's been an event, whether that be a release of PFAS, like what happened here in North Carolina with the Gen X. However, Smalling et al. Just released this paper. That's a group over at the USGS that conducted some sampling of PFAS in US tap water, which was mostly from private wells. They collected 269 well samples. However, they only collected 5 in Virginia. And that they determined that at least one PFAS compound was detected in about 20% of these well samples. So as we move forward and in partnership with the Virginia Household Water Quality Program, which tests over, I believe collects drinking water sampling kits from about 90 counties in Virginia every year, and the US Geologic Survey, we determined that we were motivated by several factors, including that drinking water is hypothesized to be a primary exposure route for the consumption of PFAS for humans, as well as that private drinking water supplies, as a result of a lack of point of use treatment, can be uniquely vulnerable, as PFAS is typically detected in groundwater. As well as the fact that US EPA regulations and is rapidly changing. Over the course of this project alone, both the health advisories and the expected MCLs were released and changed 3 times, which made the explanation of health risk to participants in this study particularly difficult. So we had 2 major questions when it came to private drinking water systems. First is that because this was one of the first efforts in Virginia, we were interested in whether or not PFAS compounds were even detected in private wells at the point of use or in private groundwater systems. So this would include just the well. Also, we were interested because we're partnering with the Virginia Household Water Quality Program. One of their important aspects is that participants collect their own drinking water samples and then return them for analysis. So we wanted to know if, because PFAS is something that requires a great deal of care and QA/QC, we were interested to know if participant collection of samples for PFAS analysis introduced bias when compared to these expert collected samples that followed very rigorous protocols. So for our study methods, we selected 2 counties in Virginia. These were counties that had historically high participation in Virginia household water quality sampling programs, as well as had similar geologic compositions, meaning that they had similar bedrock and similar soil type, as well as that Roanoke was considered a little bit more urban, while Floyd was considered more rural. So what I did was I went to all of these homes. It was 20 in total, 10 in each county. And I collected a sample from inside their home at their point of use. This is most likely a kitchen tap. I collected a PFAS sample as well as for pH and conductivity. And then I went outside and to some kind of spigot or tap outside, I collected a PFAS sample there as well as for pH and conductivity. Then I left the homeowner or the participant with a sampling kit, which you can see in the picture here. And these homeowners collected 2 PFAS, they're technically flush samples, as well as of a Hopkins sample kit, which was, includes a suite of different things to test for that are health-based contaminants, including bacteria. So things like E. coli, coliform, as well as inorganic ions like lead and copper. I won't be able to talk much about these results and the survey results for this project, but if you have questions, I do have some slides at the end. So when we talk about the results that we saw from the PFAS testing that we completed here, we can see a variety of not only inter-home variability, but intra-home variability, which really indicates that perhaps there's more happening here in the system than we'd expect. However, at least one PFAS compound was detected in 88% of in point of use samples. So that is between both the expert and the participant collected sample. The average sum PFAS concentration at this time was 23.5 parts per trillion with a maximum of 160 parts per trillion. No samples here exceeded the US EPA's proposed health index limit, which was released in 2023. 2 homes in Roanoke County exceeded the proposed MCL for PFOA, which was 4 parts per trillion, as well as 2 homes, the same 2 homes plus an additional exceeded for PFOS, so 3 in total. And 0 homes in Floyd County exceeded the MCL for PFOA or PFOS. So the literature suggests that there are additive health effects when looking at PFAS. So whether if you're exposed to one, your chance for negative health impact increases when you are exposed to more than one. So we're interested in here in looking at PFAS in mixture. And the average number of PFAS compounds in a single point of view sample was 3, while outside is a little higher at 3.4. As well as 66% of these total samples, so of all the samples collected both inside and outside, contained equal to or greater than 3 PFAS compounds, indicating that mixtures are pretty common when we're sampling groundwater. So we're interested to see if perhaps some of the detections of these PFAS compounds are related. This here is a Spearman's correlation matrix for non-parametric data, which shows the direction and strength of relationships across all detected PFAS or various detected PFAS across the collected samples. So this is all 80 of them, all 80 samples. And we found that a variety of legacy PFAS were frequently detected with their short chain replacements. So this means that the PFAS that were phased out are being detected, some more likely to be detected with some of those other PFAS that were created by industry to replace them. And we found that higher concentrations of HXA and PFBS were indicative of an overall higher some PFAS value. And higher concentrations of legacy PFOS were likely to correlate to concentrations of PFOA, which is another legacy PFAS, and PFHXS, which is actually an unregulated PFAS at this time. So when we're looking and we're thinking about these participant expert collected samples, we were wondering whether or not experts or homeowners would introduce bias when collecting their own samples. And we found that these 2 groups, when compared to the first PFAS flush sample and the expert, we found that these groups were significantly different when run through a Wilcoxon signed rank test, as well as when an expert and a homeowner were also significantly different with the second flush sample. However, we found that the directionality of these 2 groups was different depending on the sample, which leads us to wonder if perhaps time of day is something that's contributing to these changes in directionality and these significant differences. So although this work was considered a pilot study, we have several conclusions we can draw here. The first is that PFAS detection in Virginia private wells is common but variable. Like I said, we saw not only inter-home variability, but intra-home variability. The detection of more than 3 PFAS compounds in mixtures also common, indicating that perhaps the exposure to PFAS in complex mixture is also common. A variety of different kinds of compounds, including both legacy and replacement PFAS, were also detected. So of the 31 PFAS analytes that we could test for, we detected about 15 of them. And although we have homeowner and expert collected samples showing inconsistent bias, we believe that we can still rely on participants to collect their own samples in the future. And perhaps this leads us to more questions about whether or not PFAS in systems is something analogous to lead, in which there is a flushing pattern. In addition, typical drinking water contaminants are persistent, and even in homes that have tested their water in the past, which we're welcome to talk about more in the future. So when we're thinking about what's next, we're going to expand this testing to include several more counties in Virginia. We actually just ran the first part of our second phase of our study, which included both retesting in both Floyd and Roanoke counties, and that's now 77 total wells in those 2 counties. And in November, we will have testing a testing clinic in Accomack County, which is out on the eastern shore. And then Northampton, Buckingham, and Albemarle counties, which are in the central part of the state, are going to be taking place in the beginning of next year. And these obviously all represent different geologic regions, different soil types, and different well characteristics. We also found that we will be looking to create a public education and communication material through cooperative extension. So this will allow us to communicate health risk to homeowners as well as treatment information, should homeowners be concerned about their PFAS concentrations. However, under the guise of constantly evolving regulations, this is particularly difficult, and hopefully we can get some MCLs finalized in the near future so that we can better explain this risk to homeowners in the future. And also some additional funds from the NIH also are going to help us explore some human health effects and through some hopeful future collaborations. So thank you so much for your time, and please let me know if you have any questions. PFAS leaves people speechless. Yes.
So,
I'm sorry.
my family had. I had, up in Rhode Island, I have been doing, some water testing.
Yeah.
And, opinions about it, and they have started a PFAS program.
Yeah.
Are there, is that going on across the country?
Is there well testing?
That there's public water testing available. I mean, you have to do the legwork, right? You have to do the home analysis sample.
Yeah.
But then the lab will test it for you. And Rhode Island is just beginning the PFAS program. I'm just wondering if there are other states beginning that too.
Is this through the state or, okay,
The state coming out.
okay, I imagine this is probably taking place in some states. Because it's a state-by-state operation, you know, some are moving ahead more quickly than others. I think there's a variety of universities and cooperative extension offices that are working on testing PFAS. However, at this time, when there are states that are slower to begin that testing, then those things are really just lab by lab or kind of private labs testing PFAS rather than the state being involved. So it's great that Rhode Island is doing that. I wish other states would follow suit.
Thank you for a great presentation.
Thank you.
Just a small observation from Europe. In Denmark, everywhere they have tested the PFAS, they find it in the oceans,
Yeah.
they find it in the foam from the waves.
Yeah.
So now they've just been testing all the surface to see how much it's accumulated in the body. So this is the biggest thing within water quality.
Absolutely. I agree. I think, you know, that's tough for us as we move forward with PFAS. Is that, you know, when we're looking at rural areas, especially in Appalachia, you know, they're facing all kinds of water quality issues like bacteria and lead, even arsenic. And when we're thinking about these communities, how can we ethically test them for PFAS as we, you know, they're facing issues that are, you know, laid from, have been going on for so long, and now we're introducing new and unregulated contaminants that are problematic to their health. I think this isn't, like I said, PFAS is an everyone problem, and I don't think it will be something that will go away or get better anytime soon. Hopefully it will, but it's very daunting. Yeah.
Thank you, fantastic presentation.
Thank you.
Maybe a silly question, but what is the source of the PFAS in the water source? Is it from the rainfall? Like, are the PFAS collected in the rain and then it leads into the groundwater and then it gets into the wells and then they go to the households? That's my first question. And my second question is, so now these households know they have PFAS. So what kind of recommendations would you provide to them? Like what kind of water treatment options?
Great. Thank you for those great questions. The first is that, you know, PFAS has a variety of sources and it moves throughout like I said, it's essentially ubiquitous in the environment and through a variety of environmental matrices like soil, water, groundwater, rain. So partitioning where the specific PFAS compounds are coming from is often rather difficult. We kind of, you know, in some of these more urban areas, we can kind of assume that we know where the PFAS is coming from, whether it be a larger factory that used to produce PFAS, or perhaps it's an unlined landfill or a nearby airport. The things that use PFAS regularly, we can kind of pinpoint those sources. However, when, you know, you have a very rural county like Floyd County, and they still have PFAS detected in their wells, you know, who's to say? And that's, you know, again, further questions that we should be working to answer. And perhaps it's rain, perhaps it's groundwater, perhaps it's, you know, years of use of PFAS products in the home and around the home. You know, those are very unique questions. For your second question, that's a great point and something that we'll be addressing in our cooperative extension publication, hopefully coming soon to Virginia residents. But usually we recommend something like reverse osmosis or perhaps a carbon activated filter. However, those come with their own, you know, issues for wastewater and under Superfund, as you know, you're collecting PFAS and then you have a filter or a stream of wastewater that's full of PFAS, or perhaps a, you know, a GAC filter that is concentrated with PFAS. So it's a very wicked problem, and until we find a method for destruction, I think this would be something that goes on for a while. Thank you.
Do one more question.
Yes, and I'm available after if anyone has further questions. Sorry.
Oh, thank you.
I talk a
I'm
lot.
gonna make a quick comment that now under some of the standards, the NSF standards, there are claims for PFAS reduction. Originally it was PFOA and PFOS, but now it's been expanded to a mixture of, I think, 12 or 14. So there are products out there that have been certified to reduce.
Yeah.
from that level.
Yes, there have been filters that have been certified for that now. Yes, that's true.
It's great talk, and obviously,
Thank you.
this is a challenge. We did some work with solid bottled water too, and with the untreated bottled water at higher levels, where if you go with traditional treatment, there's left. One of the big challenges for all of us in the drinking water industry is if we concentrate this, the drinking water industry now has responsible sometimes what to do with this concentrated
Right.
compound.
Yeah.
And so these unintended consequences of what 4E and the companies have done have now come across the world actually in there. So we're in for a pickle of a ride, but thank you for your work.
Thank you so much. Yes, absolutely. And yeah, a lot of both wastewater and drinking water treatment, what treatment plants are kind of the reason for the holdup, I believe, is that they're trying to get exemption from Superfund regulation as they concentrate these PFAS removal techniques. So
And
again,
wastewater biosolids.
I know, right? So yeah, it's messy, but thank you so much.
All right, please welcome Harriet Mirieri, from Washington State University.
Thank you all for joining this session. I'm Harriet Mirieri from Washington State University Global Health Program in Kenya. Today I'll be talking about the assessment of water quality in non-household settings in 2 urban counties in Kenya. So unsafe water is a leading risk factor for waterborne infectious diseases, and it leads to up to 1.2 million deaths globally annually. And despite the emphasis on water quality in the household settings, vulnerable populations such as children are at a high risk of getting exposed to the effects of consuming contaminated water outside the household setting. And although it's not usually a standard requirement to chlorinate water that is used for hand washing, this water is often used for other purposes, such as drinking. And for drinking water, WHO recommends a free chlorine residual of between 0.2 to 0.5 milligrams per liter, and no detectable E. coli, which is also an indicator of fecal contamination. And also, the water should not have total coliform bacteria, which is often used as an indicator of the disinfection efficacy in water. So onto the methods. We conducted this study between November 2021 and February 2022 during the late COVID-19 response in Kenya. And we sampled locations in Nairobi County, which is the capital of Kenya, and another city that's Kisumu County, which is on the western side of Kenya. And we sampled 11 schools in the informal settlements in Nairobi, and 30 public health facilities in Kisumu County, and 20 community locations in Kisumu. And these community locations included bus terminals, public health, public offices, or rather government offices, and markets. So we sampled hand washing stations and collected samples from these hand washing stations. And we also collected drinking water samples and main water samples in locations where these were accessible. And we also conducted the free chlorine residual testing on these samples using the field test. That's the hash color
coded test that we used. And if the FCR was below 0.2 milligrams per liter, which is the WHO recommended for drinking water, then we collected a sample that we took to the laboratory for microbiological testing. And we tested for E. coli and total coliforms in the lab using the IDEX Colilat 18 test. And due to resource limitations, we were not able to test for all the microbiological indicators in all the samples that had below 0.2 milligrams per liter recommendation for WHO. So that was our testing algorithm. So we collected the hand washing station water, water for drinking, and water from the main water sources in those facilities, which we conducted the free chlorine residual testing using the field-based test. Then if this FCR was more than 0.2 milligrams, then we provided feedback to the facility in charges of school principals, and also we conducted training for the public health officers and who were also tasked with the continued monitoring of the water quality. And if the FCR was below 0.2 milligrams per liter, then we took 100 ml sample, which we transported to the lab for E. coli and total coliforms testing using the IDEX test. And in the lab, these were incubated, the samples were incubated for between 18 to 22 hours at 35 degrees. And after that, they were assessed for color change and under visible light for the total coliforms, and also under the both visible light and fluorescent light for E. coli. And for the places where the samples had E. coli or total coliforms, we also provided feedback to the school principals on these, and also they are in charges of the facilities, the health facilities and community locations. This water was also tested for chlorine, and the public health officers for these areas were also trained, and they were also tasked with the responsibility of continued monitoring of the water quality. Onto our results. So we collected a total of 192 samples across the schools, health facilities, and community locations. And of these, 91% of the samples had chlorine residual levels of below 0.2 milligrams per liter. And we managed to only conduct microbiological indicator testing for 70% of these samples. And of those samples that we conducted the microbiological testing for, 90% of them were positive for total coliforms. And 51%, that's about half of these samples, tested positive for the presence of E. coli. Our second table on the results for the intended water use. So for the drinking water, we collected only 19 samples, and only 17 were tested for the microbiological indicators. And of these, 57% were positive for total coliforms, and 43% tested positive for the E. coli. Most of our samples were from the hand washing stations, as you can see, and of those that were sensitive for microbiological testing, 90% were positive for total coliforms, and 48%, that's about half, were positive for E. coli. For the main water sources that we tested, 95% tested positive for total coliforms, and 61% tested positive for E. coli. We also conducted a logistic regression analysis to see the associations between the characteristics and the presence of E. coli and total coliforms. And we found that for hand washing station water had about 7 times higher odds of total coliform contamination compared to drinking water. And similarly, our water sources had about 14 times higher odds of total coliforms presence compared to drinking water. And our conclusion, across all the water samples that we tested, majority of them, that's 91%, did not meet the WHO recommendations for drinking water. Secondly, consistent and sufficient chlorination of water at the end user is necessary to reduce the risk of taking contaminated water. And there's also a need to encourage or standardize the chlorination of hand washing station water, because this water is mostly used for other users, such as drinking, especially by children in schools who are a vulnerable population and they are at high risk of contracting the waterborne infectious diseases. So these findings have been disseminated to the school principals and the community location in charges and the health facility in charges, and the intervention efforts are currently ongoing. And top of the intervention efforts that we are doing is that the public health officers have been retrained, and they are also acting as trainers on the free chlorine residual testing and chlorine treatment. And they are also tasked with the mandate of continuous monitoring of the water quality in the settings that are located to them or that are within their jurisdiction. Secondly, the teachers and the schools have been trained on FCR, that's free residual chlorine testing. And lastly, the schools have been provided with the free chlorine test kits. That's the rapid test that the teachers use to periodically monitor the levels of chlorine in the water that the children use in the schools. And also the chlorine dosing units have been installed in the main water storage tanks in all the 11 schools. So for the chlorine dosiers, as the water gets into the main water storage tanks, the water is chlorinated before it gets into the storage tank. And those cartridges are changed periodically. When they run out, they are changed so that to ensure that the children in the school use chlorinated water. Acknowledgement, we would like to acknowledge our funders, that are CDC, and also to acknowledge our implementing partners, which include the Safe Water and AIDS project in Kisumu and CFK Africa, that's the Carolina Popivera Africa. And lastly, to also acknowledge Washington State University. Thank you. Any questions?
So with excellent presentation. Were some of the samples from the municipal water supply, did they have chlorine? Because I saw some of your water source samples had chlorine above 0.2 milligrams per liter.
Yes, so some of the water sources, majority of them actually were from the municipal water, and most of those from the municipal water had chlorine.
Thank you.
So for your intervention, I was wondering how sustainable they are, because I believe it's a project. So when it ends, how are they going to be getting the chlorine to the testing level?
Okay, thank you for that question. On the sustainability part, especially for the schools where we have installed the chlorine dosers, there have been conversations with teachers on the sustainability of these projects, and some of the discussions that are ongoing is for the teachers to allocate a budget for the chlorine cartridges once this project is over. So that's an ongoing conversation. Chlorine doser is about $30, and it's what schools they can really afford with the money that they receive from the government. So it's an ongoing conversation for sustainability.
Thanks, everyone. Big thanks to the guys today. Thank you for coming.
Yeah.
Yes. Yes.
On my back.
Here's how these are funny. What's the?
Great job, moderating. You are the best. Thanks.
It's really. I would be surprised. Some of these are research. Yeah, the clinicians aren't.
Then I'm talking about the canal.
This should be no balance. Yeah, no. It's not there. Like reuse nature or like.
Yeah, questions, I'll get out of here. Thank you.
Right, exactly. But yeah, absolutely, yeah. So some colleagues, and they have a first thing that project. So we also in every year lab, but we didn't want to get it all. I still have it in there. I don't actually have, yeah. This one for the direct event plan, everything. We had like obviously just like guy and getting beach bounce or you know that outside of guys system we had kept on too big. So I don't see it's like the bottles themselves are all essentially like all my collaborators email who does have illustrated, like, you know, maybe on the cover or last week, I did it now, like, started having my first yeah, this thing that the office where it's quite ridiculous. Like there's no process here. It's not. You know, we have the 250 bottle and then it's extraction like in the same machine that else. That opportunity for innovation lab. And that's when you get those to the local. I don't know what to do. Yeah. That's a real pain, like, it feels so much easier without the way that it's. Yeah. Yeah, they did have. Good question. Well, actually, I found this. I feel like her, like, so like, hopefully, is like, rejection and like changing things to bring that. I had to hand it there, and like now we have all this straight. I don't know, shake your head, like, you know, sometimes they really can, you learn a lot of lessons. Which like, I don't know, but I don't know if there is. It's a real pain, and like, I'm gonna mention these on. So, really is like, anything from having yeah. It's